and welcome to the Board of Health meeting for Louisville Metro Department of Public Health and Wellness. Today is October 2nd, 2024. It's 8:01 a.m. and the board meeting is officially called to order. This virtual meeting is being streamed via Facebook and also will be rebroadcasted on Facebook and YouTube. Let's remember that the two epidemiological alerts issued by the CDC are still in place for Mpox and for Oropuche. So both have travel health notices level 2, and this involves our city for Oropuche. So the recommendation is practice enhanced precautions as recommended. The September board meetings, the September Board of Health minutes were distributed to the board for the review prior to the meeting. Are there any discussions or amendments to the minutes?
This is Dr. Shah, motion to approve.
Thank you very much. Are there any seconds? Thank you, Ms. Haskell. Appreciate it. So we move to approve the minutes as distributed. Thank you very much. So now we begin another cycle, another journey in the Board of Health. Thank you so much. Welcome to the new board members who were appointed by Mayor Greenberg on July 31st, 2024. Welcome Dr. James Ransdell, DMD. It's a co-founder of Louisville Free Smiles Clinic and also board member for Family Community Clinic. These two nonprofits do a lot of good things for the health, not only physical, but dental for the whole community, particularly for those underinsured or uninsured. And he also has his private practice. Welcome, Dr. Ransdell. Dr. Mark Burns, he is a physician, a specialist in infectious diseases. Welcome, Dr. Burns. He has a history of researching and being a professor and also doing a lot of volunteer work with Louisville Metro Public Health and Wellness. Welcome to Eleanor Manson, BSN, and a healthcare executive who has been with us as a part of the community and now part of the board. Welcome, Ms. Eleanor. We're so happy you are part of the team now on an official way. Welcome also to Dr. Scott Hedges, psychiatrist, Seven Counties Chief Medical Office. We will be enriched by all your knowledge and your experience. And of course, grateful for the reappointments of immediate past chair, Ms. Heidi Margulis and Dr. Emerald Eccles. Thank you so much. So usually the Louisville Metro Public Health and Wellness Board of Health meetings will follow JCPS calendar. This time we didn't realize that, but from now on we'll continue on or working on that. I'm also working and will continue working on the survey that we'll distribute to the board members to ask for their input regarding priorities, areas and concerns, any policies or ordinances that call your attention. We will distribute this survey via email, and the proposition is to get together for a board strategy meeting in late October or early November so we can plan for the next year ahead. And we will include dates and times. We are planning on 3 hours, but we can make it shorter. The most important thing is just to interact with each other and to get to know each other on a more personal level to favor the work that we will continue doing. So we are starting the flu and upper respiratory infectious diseases season. So let's promote vaccination for our communities and do the introduction of updates on the mRNA COVID-19 vaccines. The Brit Access program is no longer available, so we will be looking for access to vaccines for uninsured or underinsured populations, but the Bridge Access program still covers home tests to be distributed to every single household. If you haven't yours, please do so. The United States Postal Service will deliver 4 tests per household. Now I would like to pass to our perspective session. this month, we have a harm reduction as a topic, and we will have Ben Goldman and Takeisha Nunez. Ben Goldman joined Louisville Metro Department of Public Health and Wellness in 2018 and currently leads the Behavioral Health Equity Team. He and his team work to eliminate inequities associated with substance use and mental health by addressing root causes, including the legal system, access to services, education, and transportation, all these huge barriers for some populations. Under his leadership, the team has launched an overdose quick response team, convened partners to create a community-wide suicide prevention plan, and helped Louisville become the first city in the South to provide Narcan to people inside of its jail's dorms. A really important endeavor. Takeisha Nunez is Health Education Coordinator Senior for UK Target 4, and her team operates mobile harm reduction service sites in partnership with Louisville Metro Public Health and Wellness Department. Welcome both, Mr. Goldman and Takeisha Nunez. I present you to both. And Ben, if you have your presentation ready, if you would like to share it, do so at this time, and I yield the floor to you.
Absolutely. Thank
You
you
have
so
20
much.
minutes.
And thank you, board, for having us here today to talk about this very important public health topic and one of my personal favorite subjects to discuss in public settings. So we're going to give a little overview before we get started. I know many of you are very familiar with harm reduction and what our department is doing around harm reduction. But for those who may not be, I want to give a quick overview sort of the history and philosophy of harm reduction and some examples to situate it within public health. Harm reduction really is a pretty simple concept. It's the radical but humble recognition that people are experts on their own life and they make choices based on the choices that they have available to them. So rather than taking a judgmental, stigmatizing approach to behaviors that carry a risk, it recognizes that all of us engage in behaviors that carry risk, and that many times necessary behaviors include risk. Behaviors that we include in our daily life contain risk, and that rather than trying to abolish all risky behavior or shame people into not engaging in behaviors, really the most sensible, ethical path is to provide support, education, and resources to try to limit the harm that those risks present, reduce the risks, and limit the damage that those risks present. And so this is an idea that really, did not originate within harm reduction, within public health. Harm reduction originated among people who use drugs, and people who were experiencing the worst outcomes during the AIDS and HIV epidemics, LGBTQ communities, and really the communities who are most impacted by negative health outcomes associated with unprotected sex and substance use. And I want to name that because while public health has become a champion of these ideas and we've really adopted them as their own, I don't want to erase the history and the roots of these. That these are ideas that came from the communities that were most impacted, and they were later adopted by us in the professionalized public health space. And really, the harm reduction model aligns very closely with other public health initiatives, right? So I think my favorite use of harm reduction in my day-to-day life is as a driver in Louisville. I recognize the system of transportation that we have in our community, for better or for worse, is very dependent on automobiles. I am a native New Yorker. I do not like driving. I did not own a car until I was 30. But I recognize that to do my work, in order to get from my home to the office, in order to do home visits, I have to drive in Louisville. There's really not any other options. And driving is inherently a risky behavior. There is risk associated with it. People die every day of car accidents. I drive on 264 with some regularity, and the Waterson is littered with car wrecks on either side of the road. So somebody, an outsider, somebody from New York might look at me and say, Ben, you're an idiot for doing this risky behavior. Why are you driving? Why are you taking your life into your hands with these crazy Louisville drivers every day? And really not understand that for my life, where I am right now, it is necessary for me to drive. It is the best option I have available to me. And so what I answer to those folks is, listen, it's not up for debate whether or not I'm going to drive. I'm not ready to give up driving. I don't think biking would be safer. The bus doesn't go where I need to go. The car gets me where I need to go. But there are lots of things I can do to reduce my risk of negative consequences of taking part in this inherently risky behavior. I can wear a safety belt. I can obey traffic rules. I can make sure that I've gotten a good night's sleep. I can make sure that I'm not intoxicated while I'm driving. And all of these, in fact, are public health best practice. So what harm reduction when it comes to substance use involves is really just applying that exact same acknowledgement that I, as an adult, am best situated to decide which risk behaviors I'm willing to engage in, what works for my life, and then try and support me, put in infrastructure, put in education, put in resources that will prevent that risky behavior from leading to a negative consequence. So we talk most about this in terms of fatal overdoses. And what that looks like is overdose education, right? Teaching people about what risk factors are for opioid overdoses, um, testing drug supplies, making sure people have fentanyl test strips, xylazine test strips available to them so that they can have a more informed decision about what's in their drugs that they're using. Naloxone distribution, right? We, every day in Jefferson County, have residents who are saving lives, and many of those people are people who themselves are using drugs and reversing overdoses of their friends and family members who are using drugs. So naloxone distribution is a cornerstone. Our naloxone saturation is an effort to make sure that, because we know many residents will use drugs tonight, we want to make sure that the people around those residents have access to the resource to save the life of their loved one. But not only does that bystander trainer come into play, we also think it's really important to have informed decisions, right? The infrastructure, making people aware of what's in their drug supply, helping to build a narrative as we learn more about the changing drug supply that's then clearly communicated to residents that now pills that purport to be prescription drugs that are being sold on the street are overwhelmingly counterfeit. And this is a relatively new development over the past few years, and something that still many of our residents purchase a pill that looks exactly like a prescription drug. They use that pill, and then they're surprised to learn that it was pressed fentanyl. So that education piece, and really thinking about prevention and sort of fact-based, evidence-based youth prevention. All of these are kind of within the continuum and menu of harm reduction interventions, and all of them are evidence-based efforts to reduce fatal overdoses. But fortunately, harm reduction when it comes to substance use doesn't only reduce fatal overdoses. So now I will pass the mic to my esteemed colleague Takeisha to talk a little bit about all of the positive health outcomes associated with harm reduction beyond fatal overdoses and some of the lessons learned from operating mobile harm reduction sites.
Hello, everyone, and thank you for having me. I am excited to be here today to talk about this. I've worked in HIV for over 11 years, and I know how important this subject is. I know a lot of people are familiar with, we always talk about it, Scott County, Indiana, that happened around 2015, and that huge HIV outbreak that occurred due to illicit drug use. And that was kind of the birthplace of why we got harm reduction services in the city. In 2020, I transitioned over to UK from the health department and began to operate our outreach harm reduction services. With that, we did find a lot, a HIV cluster that occurred in our community here in Louisville. We would not have found that had we not had syringe service programs in the community. We were able to go in and build trust. We were able to go in and talk to people about the importance of HIV testing and the importance of Hep C testing, so that they would get tested. We know that if you are tested for HIV and you become virally suppressed, you are not going to transmit HIV to other people. It is the idea of U equals U, undetectable equals untransmittable. So being able to identify new cases, being able to help with that linkage to care, during that time, we worked with 550, Norton's, and a variety of other private doctors to kind of help people get into care. Mainly 550, they had the Rapid Start program. So we were able to call and in a lot of cases get people right to services so that they could get their blood work done and to get on medication. And some of those people are virally suppressed. Of course, there are always cracks in the system, but being able to be in places where they know we're at. So as being said, of course, the idea is everybody becomes virally suppressed, everybody gets on their medication, but it's about meeting people where they're at. And it's also about being in places where you're accessible. So when there are people who weren't quite ready to deal with their diagnosis, they were able to come back and say, hey, Takeisha, or hey, someone on Takeisha's team, I'm ready. Can you help me to get into care? We have with hepatitis C, as you know, Kentucky always seems to be a leader in people having hepatitis C. That's especially true in our drug user community. But with being in outreach locations, we are able to give them different options. We have been able to talk to people about telehealth options. We have begun to build new partnerships with offices that are now able to provide transportation for Hep C, which is something that is really new. It's something that has not happened. They are able to kind of bypass the pre-authorization, which was in the past a hindrance of getting people into treatment for Hep C. We also know that people who use drugs do care about their health. And so once people are cured from Hep C, they are less likely to to re-get the virus and spread. Even those people who are not cured, we do have a lot of conversations with them about true practices of how you get Hep C. So whether you have it or you don't have it, if you do, this is what you need to do to prevent spreading it to other people and to keep yourself safe from getting any other strands of the virus. And for people who are Hep C negative, we're able to have those conversations about how do we get you the safer supplies that you need to stay Hep C negative. We are able to offer testing on a regular basis. Right now, we try to test people at least 2 to 3 times a year. That way, we're able to catch HIV diagnosis quickly. We know that a big problem in Kentucky is concurrent diagnosis, where they find out they have HIV and then within a year they find out they have AIDS. So being able to actually meet people where they are, to destigmatize the fact of getting HIV tested is something that is really important. So some of the things that we've been able to do is really help with linkage to care. We understand that the population that we serve is one that is more of a sensitive population that may need extra supports that some of us who are more privileged do not. We have people who are helping people get medication. So we work with a huge houseless population where having medications available is harder. You know, a lot of us understand if we have kids that some people don't know how to have conversations on the phone with medical providers. So we're able to bridge that gap, meet them at the doctor's office so that they can have those first conversations and get into care, do that warm handoff to case managers, because our case managers, like at KCCP, aren't in the community and we're often able to have more touch points and to help people to get into care and become virally suppressed. Most recently, one of my team members was able to help someone secure housing, and that was a process. So like being said, bus system isn't always the easiest to navigate, but she was able to help them to navigate that. She was able to work with the case manager to get them transportation to a couple of places to get that started, to get an ID, to go to those housing apartments. And now he is stably housed and working with his KCC case manager. We're also learning that sometimes we have to be in other places. I think that's the biggest piece of meeting people where they are. Those pop up locations, we're able to touch different people that we haven't seen. One of the biggest pieces that I've learned since working in syringe exchange since 2015 is that there can be a lot of distrust when it comes to medical providers. And we're able to have those touch points with them to kind of make that easier. We've worked with nursing students who've come to our outreach locations to do blood pressure screenings, to do blood sugar tests, to kind of start to build those positive relationships and positive interactions with our healthcare providers, so that in the future they'll feel more comfortable when they have an abscess, or they'll feel more comfortable when they're needing to get medical treatment, which we know that a lot of times they kind of shy away from. And that is like engaging people where they're at is what's needed. There are a lot of people that I know that if we weren't there being able to offer these services for what they need at that moment, that they wouldn't be able to get the services for the things that they really need, like their HIV or Hep C care.
I know the board is interested in focusing on policy, so we've put together a few considerations for applying a harm reduction lens to policy. The biggest one being sort of what you heard at the start of this presentation, right? That harm reduction is really about non-judgmentally reducing negative health outcomes, not about eliminating behaviors. So in this country, we have seen the past 50 years billions of dollars invested in an effort to stop people from using drugs, stop drugs from getting into our communities, stop people from having negative health consequences through an effort of criminalization of the behavior. And we have seen that that hasn't worked. But the successful initiatives that we've seen around substance use have been these efforts to reduce harm, to prevent disease transmission, to prevent infection, to prevent overdose. So really, just when we're discussing an issue, whether it's substance use or any other health issue, really avoiding the stigma of individual behaviors and figuring out, like how can we ban a person from doing a thing, and instead focusing on reducing the harm that that behavior might cause. I think we saw a ton of success during the pandemic in taking this approach, right? Being inside with other people during a global pandemic is a risk factor. And we in public health were painfully aware of that. We as a local government were aware of it. And also we knew that it wasn't feasible for 2 to 3 years, ban people from gathering indoors. So instead, we supported all of the different ways that you could reduce the risk associated with that behavior by advocating the wearing of masks, testing to know whether or not you pose a risk of infecting other people, prioritizing engagement with the most impacted communities, making sure our applications were accessible in many languages, and really focusing on that partnership. I think that our department does phenomenal work in harm reduction. We have our harm reduction outreach services at Gray Street that provide safer injection supplies, overdose education, linkage to treatment, HIV and Hep C testing 5 days a week. We have our overdose quick response team that visits people within 72 hours of them having their overdose reversed to offer in the field free harm reduction services, free overdose education, free confidential linkages to services, naloxone distribution, linkage to treatment, linkage to medication for overdose or for opioid use disorder. All of those are phenomenal. And as we learned in COVID-19, our department cannot do this all alone. So recognizing that there are community-based organizations that reach populations who are hesitant to come in to the government, recognizing that it's through partnerships with trusted community organizations that were able to reach a wider variety of our residents, and knowing that, you know, the government, for many reasons, doesn't always have the best reputation with communities of color, with immigrant and refugee populations, with houseless populations, and with folks experiencing substance use disorder. So really just that humility of recognizing that we do great work, and also, despite all of that, we're up against decades of history of missteps in how criminalized substance use has been handled.
And I'll throw in one more thing really quickly. I think one of the most important things to realize is that it's a lot easier to reach a population that's at risk when you have a relationship with them, instead of trying to reach them after something has happened. And I think a really clear indication of that was the Hep A epidemic outbreak that we had here in the city. Because we had those relationships at the syringe exchange program, and I know, and Ben knows because we were in there working with it, people said, I will get this vaccination because I trust you. I think that it would have been a lot harder. I know it would have been a lot harder because I know how we stacked up versus other counties in the state with getting our most vulnerable populations vaccinated. And so when we're able to be out there and meet people where they are and to have those relationships, that just truly impacts the way that public health is utilized in our city.
Thank you very much to both. Very enlightening. Thank you so much for letting us know that there is a quick response team, Ben, and then there is a follow-up for those that have received help previously. So if you have time for questions, are there any questions from our board or our community members? Ms. Maria Marta Sanchez wrote, some staff, including myself at the nonprofit where I work, staff underwent an Narcan training. I learned from Hispanic trainer at this training that the use of fentanyl drugs is sometimes a taboo subject within the Hispanic community. If able, could you speak more about overdose stats related to fentanyl within the Hispanic community?
Sure. So for many years, we did not really see overdose and overdose fatalities in our Hispanic community locally. With the diversification of fentanyl in the drug supply, especially what I mentioned earlier, the proliferation of counterfeit prescription pills, we've seen an increase among fatal overdoses among Hispanic populations locally. That trend is still upward, but as information is being spread out, as people are starting to learn, we're seeing a little bit more awareness. Anecdotally, sort of the most common story that we're hearing on the quick response team from Spanish-speaking residents who have experienced overdose is a disproportionate number of folks working in manual labor, construction, and the trades, often without access to proper medical care and access to pain management or physical therapy, who are managing that pain using pills that they're obtaining not from a pharmacy. Sometimes those pills are pharmaceutical grade prescription pills that have diverted, but many times those are pressed fentanyl. So it's not, in some cases, it may be people who are seeking opioids, but not seeking fentanyl, who are being exposed to fentanyl as a result of the toxic drug supply.
Thank you, Ben. Is there anybody else with a question for Ben? Dr. Ransdell? Yes.
Mr. Goldman, I was looking over, and I'm very new to this process, but was looking over the executive director's report, I believe, and it mentioned something about NARC administration training. And I was curious about that. I had sent a voicemail, I think it was yesterday, and hadn't heard anything back. But I was curious about how that worked, and do you have the ability to set it up? How long does the training last, and things like that? Because I have two groups that I would be very interested, and I think that needs to be publicized as well, especially among all the health sciences groups that are in the city, because I did not know it was available.
Absolutely. Yeah, our department is very eager to provide overdose education and naloxone distribution. Both our harm reduction outreach services team and behavioral health equity team do trainings every week, and we work with anywhere from 1 to 200 people. It's an infinitely customizable training. The shortest version of it we can convey to individual or group the most critical points in 5 minutes. We also have enough content that we could keep people engaged and interested for up to an hour. I think with the approval of naloxone for over-the-counter use, the FDA has determined that the writing and pictures on the box are adequate for people to be trained to use this. So I want to highlight, it is not the case that a formal training is required to use naloxone, but as a public health professional, I really value education, and there's lots of information that's not on the box about things like rescue breathing best practice, talking about ways to reduce the risk of overdose in the first place, how to support someone post-intervention, all of that that we would be happy to talk with any group about anywhere in Jefferson County, and we can even pair that with naloxone distribution for free. I can put my email address in the chat, and I'm happy to set something up for you at your convenience.
And I want to just piggyback on that for just a second, just how important naloxone training is. I train kids at the spot 16 to 24 years old. When I go in, I am asking them the question, how many of you have either overdosed or know someone who's experienced an overdose? And every time I go, over half of them are raising their hand. So this is something that I feel like even the youngest, both of my kids have been trained for years, going into high school settings or community settings, and really making sure that everyone has access to naloxone, not just for people who are using illicit drugs, but we have our elderly community that may not remember if they have taken their medication, and they may inadvertently overdose themselves. And so making sure that people know how important it is for every household and every person to have naloxone, not just for people that they may assume are doing something that is illegal or that has fentanyl in it.
Thank you very much, Dr. Hedges.
Yes, Dr. Goldman, I'm brand new to the committee. I've been part of the committee all of about 34 minutes now. Being at 7 counties, I really appreciate your presentation, and particularly at engaging individuals where they're at and try to help move them forward. I just want to seize the opportunity to gain from your expertise. I'm really curious as I look at the national policies and procedures and some of the debates that are going on at the larger national level, that at a public policy perspective, things really get a little bit more complex. And so if you look at California or Portland or Denver, that are further along than we are in some of these processes, part of the challenge that's associated with it is you have harm reductive approach, but then you don't have necessarily a mechanism to keep up with treatment that stems from that approach. You engage individuals, they may decide they want to make different choices, and there's insufficient resources available. This is a huge problem in Portland, where the waiting list for addiction treatment is months in some cases. In addition, there are other debates. I don't know if I agree with them. I haven't really formed an opinion, but there are debates about striking a balance between what a community does at a public policy level versus an individual engagement level. Can you educate me a little bit about your thoughts about how do we balance the health department's recommendations about making sure treatment is accessible and paid for, and how do we find a balance between both the individual engagement and the larger public policy? Do you have thoughts about that?
Absolutely. I have two quick disclaimers before those thoughts. The first is I'm still waiting on my honorary doctorate from Louisville, so I'm just a Mr. Goldman for now. The other is, obviously working for a local health department. I'm somewhat limited on the level of advocacy I can do specifically related to specific proposals or legislation. So I'm going to just talk very broadly. But I think one of the biggest misconceptions that I see around harm reduction and its relation to treatment is that the two are either diametrically opposed or mutually exclusive, and nothing could be farther from the truth. I think that for so many people, medication for opioid use disorder is harm reduction, right? When we look at nicotine replacement treatment for people who are smoking cigarettes, as a society, we have, and as doctors, public health professionals, have all come to an agreement that sure, right? Like in an ideal world, the person wouldn't even be chewing nicotine gum or using a nicotine patch, but that nobody is going to say that that nicotine replacement treatment isn't preventing harm from somebody who otherwise would be obtaining their nicotine from a cigarette. And I think, methadone and buprenorphine are such great examples where because of the moral weight of criminalized substance use, because of the moral weight and stigma associated with opioid use, many people don't think of methadone and buprenorphine in the same way that they do think about Nicorette or nicotine patches. But really, I think for lots of people, treatment and even abstinence is their best form of harm reduction. There are lots of substances that, for me, I am very confident, knowing my biology, knowing my psychology, knowing my lifestyle, I am very confident that any amount of use of that substance would be extremely harmful to me. And choosing not to use those substances isn't undermining my belief in harm reduction. Harm reduction isn't promoting the use of substances. It's not condoning them, but it's not saying everybody should be using substances all the time. I think often we're misrepresented when it comes to this. I think that for people who are interested in reducing their use, for people who are interested in eliminating their use, treatment and abstinence are harm reduction, right? The distinction in applying harm reduction lens to this conversation really comes from who's making that determination, right? I think that, as I said before, forced abstinence for many people does not seem to be an effective way to prevent risk, right? Our jail is a great example, right? If there's anywhere in the community that you'd think that our legal system, our policy choices would prevent people from using substances, it would be there. And I think the jail does an extraordinary job keeping substances out of that setting. And also, it is the nature of systems that serve thousands of people and the nature of people who are highly motivated to use substances that substances will get in. So what can we do? We can offer harm reduction to keep people alive and treatment for people who are interested in making a change specific to their substance use. So I agree with you. I don't want to see long waits for treatment here in Louisville. And I'm thrilled to report that our experience linking people to treatment in Jefferson County does not include month-long waits. I mean, there are people literally, the team visited somebody on Monday of this week, they had an appointment for them to start a methadone program Tuesday morning, right? This is not, we're very fortunate in the sense that even though there's a huge need here, right now there is available treatment. Obviously there are barriers to that treatment. So, may be the case if the person doesn't have transportation, that they'll struggle getting there. For someone who's unhoused, it may be a challenge to access those services, but these services here are available, and our harm reduction outreach services routinely refers people to treatment. I think it can be a both and I don't think that endorsing harm reduction and promoting harm reduction means that we have to ignore or forget the fact that treatment is a critical piece of the continuum of care for people with substance use disorder.
And I will
Thank
say,
you very much. Yes,
I was
Takeisha.
just going to say,
Last comment.
at our syringe exchange program in Portland, there is actually a doctor, Dr. Stewart, who comes out and who does medical assistant treatment and will meet people where they're at, right at the syringe exchange program, as well as a program that will pick someone up from the syringe exchange program or from anywhere if they say that they want treatment. So I think that we're very lucky in the city that we have places that we can send people who are ready.
Thank you so much. Due to time constraints, we will have to continue with our agenda, but we are very grateful to Ben Goldman and Takeisha Nunez for participating and enlightening us today regarding harm reduction. Thank you so much. Appreciate it.
Thank you.
So now it's the Mayor's Office update. I now yield the floor to Deputy Mayor Nicole George. Thank you, Deputy Mayor.
Good morning. And again, thank you to our speakers this morning on harm reduction. That was an interesting, informative discussion. I have been asked to share a little bit about the announcement that Mayor gave yesterday related with masks and gun violence. And so is this the point that you'd like me to do that, Chair? Okay, perfect.
Yes, please.
Excellent. Okay. So all this to say, everyone participating as part of the board is obviously aware that gun violence is a public safety issue. I think we have reached a tipping point for some of us as it relates to the most recent school shooting and how we see this affecting the community. And really just want to say that, we've had 291 non-fatal shootings in Louisville this year, 291 non-fatal shootings. So obviously, Mayor is doing everything he can, as is the administration and people working with an LMPD, and really looking at a multitude of strategies, understanding that we have a lot of limitations with what we can control. Mayor certainly has done a strong job of trying to advocate to Frankfurt, but we are very limited with how we can intervene in gun violence. So if we are thinking about controlling what we can control, this brought us back to an existing ordinance, which really attempts to get to preventing people from exploiting appropriate and much needed use of masks. And so we want to recognize that existing ordinance needs some work. I think it was initially passed in 1983. My understanding is Mayor did a strong job yesterday saying, we know this ordinance needs amendments. It is not perfect. We have learned a lot since COVID, and we welcome input. So I think the request I would have of the board is to say, we are open to input and what that looks like, but we really are trying to balance the threat of gun violence, understanding that we have a small population that is seeking to exploit, and that quite frankly does feel more empowered when their face isn't exposed to engaging in behaviors they might not engage in if they were more visible, with the obvious need for masks and what protections those apply, in addition to what we know currently exists in the ordinance around exceptions for rights, for example, religious rights, healthcare providers, people working in professions that would necessitate wearing masks. So again, the 1983 version has some exceptions. We know we need to see those strengthened, and we know we've learned a lot over the last over 30 years. So we want to apply that. But please hear me say we welcome input, and I'm interested to hear thoughts. Thank you.
Thank you very much for the update, and thank you so much for highlighting this very important topic. And if I recall well, Mayor Greenberg highlighted that this ordinance is applied to outside, when on public spaces. So let's, if we have ideas and contributions, let's them make note to Deputy Mayor so we can contribute with, the work that all of us are doing in favor of public health. And violence, without a doubt, it's a strong part of our public health problems. Thank you so much. Now for the director's update, I yield the floor to Dr. Inder Singhal, the Executive Director for Louisville Metropolitan Health and Wellness, and he'll also be speaking for Chief Health Strategist Connie Mendel, who wasn't able to join the meeting today.
Can I offer just a quick comment? I don't know if you saw my
Yes.
hand. Yeah.
I didn't. Sorry, Dr. Cardarelli.
Oh, no problem. I first want to thank Deputy Mayor George for bringing this. I was going to bring it up today because I was sort of wondering, if there was an opportunity to provide input. First, let me just say I highly commend the mayor for explicitly acknowledging that gun violence is a public health problem. I think this country would be better served if more leaders recognize that it is. It's a public health problem. That being said, I am glad to hear that the mayor's office is seeking input on the ordinance because it's not going to surprise everyone here as Dean of the School of Public Health that I would advocate for a population health perspective when examining this ordinance, recognizing that it is, as you acknowledged, Nicole, a very small number of individuals that are exploiting the opportunity to wear masks. And we know that mask wearing, when done properly, really can protect our most vulnerable in the population. And I do think that COVID has taught us a lot of good and bad. And one of the good is the regular practice of wearing masks indoors and even outdoors in crowded settings. So I would just offer that I've already had faculty in my school asked to provide input to an ordinance. And so whatever form or shape that can take, Deputy Mayor, please know that we would love to participate in providing specific feedback on the ordinance. Thank you.
Thank you, Dr. Cardarelli. It's much needed, so let's all contribute to the ordinance update and the amendments. Dr. Singhal, the floor, I yield it to you.
Good morning. Thank you, thank you, Chairperson. And so I'm speaking on behalf of Connie and myself, and Mayor Greenberg yesterday highlighted, as we all understand, gun violence is public health problem. Public health is an evolving field. It's not just about providing healthcare or coordinating healthcare. We all know mental health, gun violence have become a major public health problem. So you all have the executive director report. I'm going to actually go to the very end, the 988 campaign. So when you look at SAMHSA reports, the mental health and suicide has become, in my mind, an epidemic. There were, for age group between 10 and 24, it's the second leading cause of death. There were over 45,000 deaths in 2021 compared to homicide, which is exactly half of that number. Last year in 2023, there were 10% of high school students who seriously thought of attempting suicide. So keeping that in mind, we will need Board of Health's guidance actually in how do we join forces in implementing policies and enforcing or actually advocating for policy changes. As far as the 988 campaign, Metro Health has invested funds in advertising. It's a no judgment campaign, 24/7. It's a national hotline where people can reach. And I think all of us on this board, on this committee, should be sort of bringing awareness. And it starts with us here, and then slowly it percolates through the community. There is no judgment needed. Mental health is a huge issue and huge epidemic, and we have to work towards taking care of it. And then my team did a great job. You all heard the quick response team. I don't think I need to say more, except we're really proud of the work that they're doing. They're doing meaningful work. Ben is humble. He, he wouldn't highlight some of the achievements. He single-handedly has, and his team has single-handedly changed so many things in the city, including going to Jefferson County public school system, not only helping people with naloxone use, but also just prevention and helping people understand what does it mean to be drug free. And he does a bunch of work. He works in the corrections facility. I don't have the numbers in my hand. I know there has been significant use of naloxone in the facility to help inmates and save their lives. The other thing that I would like to highlight is our Women, Infant, Children program. It's in its 50th year. We have an extremely strong team serving close to 15,000 families in Jefferson County. And they have multiple locations where we serve them from. These people, without the WIC program, would be left behind. And we have a very compassionate team. Not only they support these people, they take every opportunity to educate these people and link them to other services, including Medicaid or whatever services, SNAP services, whatever services they need. You all have heard of the oropouche virus. We have one confirmed case, and advisory is we have reached out to a lot of our Cuban community members as well as the Latin American communities, and sort of guiding them, especially if you're pregnant, not to travel unless you have to travel, and try to be cautious. If you come back from a travel and you have symptoms, you should make your doctors aware of your travel. And then lastly, the COVID, someone did bring it up, that there is COVID testing is available. You can pick them up from one of the Metro Health facilities, or you can order them for kits free. The federal government is providing that. And we do have the new COVID vaccine at our 3 of the facilities where we provide vaccination. And I think that's about it, unless there's any question.
Thank you very much, Dr. Singal. I guess we don't have any questions. Thank you so much for all the information. It's key information, and we will continue to be aware of everything you have shared. For family health centers, Dr. Irwin was unable to join the meeting, but now I yield the floor to Ashley Shoemaker for healthcare coverage, outreach, and any other family healthcare business. I yield the floor to you, Ms. Shoemaker. We cannot hear you.
Muted. Yeah.
Yeah, we can hear you now, Ms. Shoemaker. No, we
I
cannot
can't
hear
hear you.
you. Um, we cannot hear you. I'm sorry.
Okay, can you hear me now?
Yes, now
Okay,
we can hear you. Go ahead, please.
so I have an update to share for family health centers. Yesterday was our opening day of our new family health centers Promise program, which is an HIV treatment and prevention program located at our Portland Avenue location. The Promise program offers assistance with HIV testing, PrEP and PEP services, HIV treatment, prescription assistance, as well as help with, appointments and connecting people to other services. So we are excited to announce the opening of this new program that I think is very timely given the perspective session. I will include the website to the program in the chat. And then for our coverage, Medicaid Coverage Coalition update, our next meeting is scheduled for October 14th at 4 o'clock.
Thank you very much. Thank you very much, Ms. Shoemaker. Do we have a representative for JCPS Health? I don't see Dr. Stone or Angela Hayes. I guess we don't have any representative from JCPS. For Greater Louisville Medical Society, Dr. Anita Bhatia.
Yes, hello. Thank you very much, everybody. It was a great report that I heard this morning from Ben Goldman. I would like to present our report. This year, we inaugurated the American Medical Association President, Dr. Bruce Scott, who is an ENT surgeon here in Louisville. He's a past GLMS president and a past KMA president, and he was also a speaker at the AMA. He's been a delegate there for a long time. And he has been elected from Kentucky to be the American Medical Association president. So we are very excited and very proud of his achievement, and we're very proud that we are on their map for health issues in Kentucky as well. And then I'd like to mention about the annual KMA meeting, which was held the last weekend in August, where we had several resolutions put up, and two of them very significant about the gun violence and the public health problem, and how physicians can address this when they have contact with their patients, to find out what safety precautions the parents have taken for the guns that they own in their houses, and how they can actually also help in making sure that if there is any violence in their household, that they expect to temporarily remove access to those guns. And so those kind of things were highlighted in the KMA meeting at the resolutions. And we did get partisan support on that, so we will be advocating that again at Frankfurt. And then we had we inaugurated a new president of the Medical Association, Dr. Evelyn Montgomery, and she has, her motto is going to be small steps and big impacts to try and improve the health situation in Kentucky, but more importantly, it is also to be talking, she brought up the fact that now we have a new subcommittee at the AMA, which is called the American College of Lifestyle Medicine. And that is in Kentucky offering free CME to the doctors about how medicine and food can change lifestyles. I know at one of our meetings, we talked about this lifestyle changes, knowing fully well that about 80% of our illnesses are from basically, and 40% of cancer is from the lifestyle and the food that we eat. So there is a great impetus on that at the moment. The Greater Louisville Medical Society just on the 30th of September had its golf outing, which is a way to fundraise for scholarships for medical students. And we raised $120,000. So we offered about 10 medical students $12,500. and that has a very popular event. And we would invite everybody to the next event, which is, I believe, the 29th of September in 2025, just to see how we encourage our medical students to be able to pay there and to be debt-free, or a small little chunk that goes in that direction. That's basically it. The rest of it that we are hoping to accomplish, I will present at our next meeting. Thank you.
Thank you very much, Dr. Bhatia. We'll be paying attention to the advocating that you'll be doing in Frankfurt and all the changes that are being promoted for being purposely violence prevention as physicians.
Thank you.
Okay, now we go to our new member for the Kentucky Nurses Association. I yield the floor to Ms. Delano Manson.
Good morning. Thank you, Dr. Batista, Dr. Patty. We are really focused this year on our priorities for the Kentucky Nurses Association to follow up on the violence prevention bill. Nothing has been done by the Cabinet for Health and Family Services. So we are very concerned that they have not released the guidelines for healthcare organizations. We're also working on how do we get funding for SANE nurses. We only have 362 SANE nurses for the entire state. And so we are working this year to cultivate legislative support so that in the funding year, next year, we'll have legislators on board who can help us get funding for that. We continue to focus on school nurses. While we have a school nurse in every school in Jefferson County, that is not so throughout the state. And so we are working on that as well. So those are our priorities for this year. Next year will be hot and heavy trying to get some legislation passed.
Thank you very much, Ms. Manson. Now for Greater Louisville, Inc., I now yield the floor to Shelby Somerville. I don't think she is in. So we will go to our committee reports. For the Immunization Advocacy Committee, Dr. Carica, do you have anything to share?
The only thing to share is our goal is to try to put together a concise document that outlines where individuals may be able to go for vaccines. So we're slow to get started. We've got our format, but I just need information to return back to me from our partners so then we can make that available. Our goal is to have just, again, very brief information and then be able to provide a link or QR code or something that will then return back to that site so individuals who want more information can access it, but that enables us then to keep a very short and concise summary. So our goal is to get not only the health systems, JCPS, what we have available through Louisville Metro, and other partners so we can address some of the issues that people have talked about, and that is where particularly do people go when they, number one, don't know where a vaccine is provided, and then how can we provide some sort of an avenue for individuals who lack coverage for vaccines. So we have our pathway. We just need information back from the partners to be able to compose that concise document.
Thank you so much, Carico. Very needed, and we certainly appreciate that hard work. Is there any old business that we need to talk about? Is there any new businesses that we need to approach? If not, thank you everybody for participating and taking the time to be here today for this month's meeting. And I want to welcome one more time our new members, Dr. James Ransdell, Dr. Mark Burns, Ms. Delano Manson, and Dr. Scott Hedges, and always grateful for immediate past chair, Heidi Margulis and Dr. Emerald Eccles. Our next meeting will be held Wednesday, November 6, 2024 at 8 a.m. Please remember, the meetings will be on the first Wednesday of the month and will be held virtually If we have any changes, we'll let you know in advance. So, and please try to log in 5 minutes before we start our meeting. If you have any changes in, if you won't be able to attend the meeting, just let Ms. Arlena, Glenn, or myself to know. And I think this is all we have. Is there any motion to adjourn the meeting?
Motion to adjourn.
Second.
We adjourn the meeting. Thank you very much. Have a beautiful day.
Thank you.
Thank you.
Thank you.